So Dr. Angela Lin is co-director of the Myhre Syndrome Clinic at Massachusetts General Hospital in Boston. A board-certified pediatrician and clinical geneticist, Dr. Lin is dedicated to the care of people with physical differences, especially syndromes that involve the cardiovascular system. She's active in numerous research projects and has published over 100 articles and chapters. At MSF, we are indebted to the work and dedication of Dr. Lin and the support she provides to the international Myhre community. Dr. Joseph Shea is a board-certified medical genetics and genomics physician. He specializes in evaluating individuals with complex medical genetic conditions. Dr. Shea's research lab aims to understand the genetic basis of diseases, particularly conditions affecting children, by using genomic and molecular tools that integrate novel technology with personalized medicine. I'm sure we will have some questions about that, Dr. Shea. Dr. Valérie Cormier-Dare is a world-renowned geneticist known for pioneering research in skeletal dysplasias and rare genetic diseases. Her contributions have led to a deeper understanding of the genetic basis of conditions like Myhre syndrome. And Dr. Lisa Schimenti is a clinical geneticist at Mayo Clinic. Dr. Schimenti's research is focused on genetic conditions associated with hearing and vision loss, and Dr. Schimenti conducts clinical research studies and studies involving zebrafish to model human conditions. So let's get started. Panelists, welcome and thank you. As I said, everyone, please ask questions in the chat. Just to give a small caveat, we will go through general themes, but if we can't really answer very, very specific details on individual cases, as you can imagine, the doctors haven't seen you or your child personally, but we will try to answer as many of the questions that you have as possible. So, panelists, please also, when I ask a question, feel free to dive in and reflect on each other's answers and build on them if you would like to. I'm going to head to Dr. Lin first, because Dr. Lin, this is one area I did send you a heads up about, and a really big topic for us in the community, puberty. So we have lots and lots of questions around this. Why do the Myhre community seem like they go into precocious or early puberty? And therefore, when is it appropriate age-wise to delay? Are there pros and cons for this?
This is a really good question, a really complicated one, and we think about it almost every month. We're finalizing our data from the MGH clinic. This is going to be put into a paper. So I'm going to try to break it down. Let's talk about, first of all, females versus males. In females, especially those who have the arginine 496 cysteine variant, we tend to see premature puberty more frequently. And I'm not an endocrinologist, but one of the important things to know is you have to break down what is pubing. Is it early breast development? Is it axillary hair? Is it pubic hair? Because the latter, when it refers to hair, is really called, breast development is pubarchy, thelarchy, excuse me. And so you need to separate out whether it's just one or the entire package of puberty. We also look at puberty in terms not only of the physical signs, but in terms of physiological signs. The main clue is usually menstruation. So one pattern, I'm just saying one pattern that we see often is early development of breast, early development of puberty. We always compare puberty in a woman to the mother's age of puberty. Okay, some women are earlier, some are late, and sometimes their daughters are like that. And then we often see that menstruation does occur at an early age. And you'll ask me for the number. Well, it varies. It varies based on ethnic group. It varies based on other variables. So onset of puberty physically and physiologically by early menstruation to us is a sign that this is early puberty. Now, the next question is why and what do we do? We don't know if the stimulus in Myhre syndrome is coming from the head, the pituitary. Is it sending out a signal to the rest of the body to start developing? We do not routinely do a pituitary MRI. We have not found anybody who has a pituitary tumor. We also don't know if the action is going on directly in the uterus. Is it possible that the SMAD4 variants, they activate something in the uterus? And one reason for this, for thinking about this, and I'm telling a story, it's a very free-flowing story, is that there is a risk that once the menstruation starts, the periods are really heavy and painful. So heavy that some of the women have ended up in the emergency room just almost bleeding out, so heavy. And that has led us to think that there is something changing on the endometrium, the lining of the uterus. Furthermore, in a small number, just a handful, 3 women ever, who had this variant, they had endometrial cancers. You may have heard about the paper that we wrote. We thought it was just striking. 3 women, how rare, with endometrial cancer and all having the same variant. I'm talking about just one part of the whole picture of Myhre syndrome. Females, the arginine 496 variant, premature puberty, including the breast development, the periods, very heavy ones. And for those women, we asked people to, first of all, work with a gynecologist. You had to work with somebody closely. People have asked, well, what should we do? Should we do an ultrasound of the uterus? And the thing is, an ultrasound could be done, but it's very coarse. It takes a lot to show a problem in the uterus with an ultrasound. What about something more sensitive, MRI? Sure, but isn't that incredibly costly, and how often would you do it? The next question is there a biomarker? Think of prostate. We have a biomarker for prostate cancer. We don't have one. And finally, what we're left with is just really good old-fashioned observation. My daughter's having periods, they're under control, or they're having really heavy bleeding. And so when referred to a gynecologist, sometimes the bleeding is managed as one would manage any woman who's having heavy, painful periods. And that can include a variety of different hormonal interventions. I'm not going to recommend any, it's a highly individual case. Now, does this scenario apply to females with, say, the isoleucine 500 valine variant? I think we have seen it. I'm sure we've seen that, but it seems to be more common in the other. Number 2, what about males? We definitely have seen males who seem to have earlier puberty, but it's often just mild, just barely shy of what is, typical. And there can be times where it is clearly. So I must tell you that we are still in the stage of, first of all, we listen to you. When anybody mentions this, we work with our patients. So we're listening, we're observing, we're working, we're trying to document, but we don't have a good reason why. And I'm going to take advantage of all these intelligent people I'm looking at. Do you have any thoughts to either support or criticize our thinking process? In other words, we're making the observation, we're trying to decide whether it's male or female or both, whether it's mutation specific, and whether it's centrally mediated from the pituitary sending out a hormone, or something that might be directly impacted on the uterus. The theory that we came up with the uterus is, could there be hyperplasia, just a stimulation and overactivation of the uterine lining, that then becomes what we call metaplasia, certainly starting to change. It's not completely normal. And then only in a small number is there actually neoplasia. So I would appreciate any help. Valerie, I know in your paper, you did note this in your patients, and I was wondering if you have any thoughts about pathophysiology.
Well, I don't have any explanation. So you perfectly explained that there are 2 possibilities, and we have never explored any uterus abnormalities, and it's a good possibility, but it's quite difficult to know it. But maybe with a mouse model, it will be easier to study those findings, and it might be helpful. But I don't know. I follow what you have been saying, and I don't have any clue.
I discovered, as many of you have, that you have an expert at your own hospital. I'm an expert in endometrial cancer, met with him and some of his colleagues. And I asked him about the value of biopsy. It would be invasive, but it would allow us to obtain tissue. And really discouraged it. A biopsy is a mere sample. You're putting a needle in one place, you'd have to poke around 25 places. So I said, what next could you do? He said, if there was a hysterectomy, if there was tissue available, in that case, we could study that. But that is rarely done, rarely done. So we kind of got it in a circle of exploration, but came to a dead end. Lisa or Joe, any thoughts?
So, at least from my personal experience, I think what makes sense for somebody who's at risk is to consider, doing a hysterectomy when someone gets to the age where they're no longer going to have children. And one of the instructions we gave to the pathologist in one case was to basically not miss an area and be really careful instead of just looking at one or two areas. And they did. So we could feel confident that there wasn't a small focus of malignancy.
Thank you for mentioning the age factor. That is very important. Joe, any thoughts about this?
I think it gets back to guidelines, numbers, and data. Without clear guidelines, it's really hard to say. I think this is definitely worthy of discussions. It's just that, numbers, other factors, familial factors, other things that could play into account to risk. I think we should be taking everything into consideration, and I'm glad that Valerie, Angela, others have been looking at models to see if that can help inform.
So folks, thank you, Joe, by the way. Just to reassure you, we're definitely thinking about it and thinking hard about it. And we're bringing in partners, mainly gynecologists and endocrinologists. And we've been taking sort of a personalized approach. There have been some patients where we have thought maybe it is important to do a pituitary MRI, but generally we have not done that. In fact, some of our patients may have had them for another reason, but we generally don't do that.
Okay, thank you, everyone. And so general guidance would be at an early stage as part of the care team to instruct local endocrinologists and gynecologists and work to monitor and see how all that is progressing for each individual case. Okay.
It's certainly a team approach. And if anybody met a gynecologist who had this expertise and they counsel the family, here's what we should do, we would do that. Often the treatment is to use some sort of hormonal suppression, sometimes an IUD. It's highly personalized, depends on the family and the scenario. Thank you.
Great. I'm going to start with a question for each of you first, and then we're going to dive into loads of detail. I know the chat is ringing up here. Dr. Schimenti, from your side, hearing loss, and I know Angela has provided with us an extra bonus edition talk on hearing loss, but from your area of expertise, with hearing loss, do we see a progression, generally speaking, with Myhre? And is it to be expected that there will be significant hearing loss as they progress? And with that in mind, would you be able to just give us a little overview on the different types of hearing loss we see within the community?
Sure. And I think Angela's going to cover this in her slide deck. So the main two types of hearing loss are conductive, which is related to the way the bones of the inner ear function, so that the cochlea, which is the structure inside the ear that hears sound, that responds to sound, is intact, but the bones of the ear are malformed, creating a conductive loss. There are also patients who have mixed hearing loss, where they have both conductive and sensory neural. And then there's a single patient in our cohort that has just pure sensory neural. And so I think Angela is going to talk about that in her slide, so I don't want to scoop her. The bottom line is that if a child is diagnosed with Myhre syndrome, and especially if their talking is delayed, or you get a sense that that child is not responding to their name or responding the way you expect, I don't think it's safe to assume that that child just may have cognitive disability or may have autism spectrum disorder, and that a child's hearing needs to be tested. The testing should be done by someone who is experienced with hearing loss. So it's not the typical hearing loss that elderly individuals get. So if the audiologist you're using is really experienced in taking care of people over 65, they're probably not the best audiologist for an individual with Myhre syndrome. And so that audiologist should be looking at both conductive hearing loss as well as sensory neural hearing loss. And there's different tools that they use to make that diagnosis.
Okay, thank you very much. Dr. Shea, we had a lovely specific question in for you, and I will do my best to read it out, and then hopefully you can explain it further to me. So can genetic nutritional profile testing help with Myhre syndrome patients? Nutrigenetic and nutrigenomic information can offer the possibility to regulate the lifestyle, positively influencing the functionality of the genes. Can this somewhat compensate for the areas in which the Myhre mutation exists? And I would like to just take a moment to recognize how wonderful our community is and how knowledgeable and fantastic they are asking questions like that. So over to you, Dr. Shea.
Yeah, so insightful. I mean, I feel like this question really gets at, one, can we look at data we have now and what can that tell us about nutrition and genomics? But two, really where the goals for the future are, right? And I think we all know a fair bit about nutrition, but combining nutrition and genomics is really on the cutting edge, right? And I wanted to, take this time to sort of emphasize the body system I don't think we've been talking about as much, and that is, joints and connective tissue. I'm glad that there's much more emphasis into connective tissue because it joins many of the internal and the more external parts of the body, right? And I think the key question is, how are the changes in SMAD leading to long-term changes in the connective tissues? And with regards to nutrition, this is so important because, there's actionability, like what we're doing every day. Can we measure that with biomarkers, what we're taking into our body? I mean, we are what we eat, right? So we should be able to measure stiffness. I know there's been some talk about that, but people are different. Everybody's unique. But I think the common thing that I've heard from people is that, people are working on their development. They're working on staying active. They want to be, healthy and running around, and they want to be able to do things themselves when they're kids and when they grow up. So if that's the case, I feel like nutrition and genomics should really come together in this way. So specifically, what do we know now? I think we know a lot of basic metabolic pathways. I don't know if people have really put them together yet based on the blood lab values that we have now or other values. So I think that's one thing we should do. I think in terms of the future, I mean, I think a lot about, my training because I got my PhD in immunology. We cultured a lot of cells. We knew about the mucosal immune system, that is the immune system of the gut, and how things were absorbed. And, we're able to make models. Even back then, a couple decades ago, when I was a PhD student, we could culture intestinal cells. We could model infections in those cells. And, I've done it before for, different kinds of brain cells, cardiac cells as well. But I feel like, and all these were done with, donors that wanted to repurpose their cells because they would have been thrown out anyway, right? So I think the models are fantastic, but we also have to think more about human cellular models and tissue models to complement everything. And I'm hoping also people are thinking about with their model systems. I know people like Valerie and Angela's team have been thinking about cells taken out from models and what they can teach us as well. So I think specifically in terms of nutrition, there's two new developing areas, right? There's RNA profiling. So your genetics gives your RNA, gives your protein, and that has been correlated to things like your microbiome or your nutritional status. I mean, nowadays we measure it, fairly basically, right? It's like vitamin levels, iron levels, blood counts and things like that. But we still need to look at those parameters to make the best sense of what's going on with Myhre. I think with the RNA, for a different rare condition, a new rare condition we published this past month, we've used antisense oligonucleotide or ASO technology to alter levels of a different transcript. And that's something I know the whole community is thinking about. So I think, there's a lot of technology that you can take advantage of that I think is important. And I think specifically for nutrition, I think we should be looking at the metabolic pathways that we know, but also in terms of a strategy, looking at other biomarkers as well. And I'll just give one more example, like, your hormones, your vitamin D, like vitamin D is affected by your intake. by sunlight, by renal processing. You know, there's a lot of things that go into it. So getting the right people to look at that kind of data to make the most sense of hormones or vitamin levels would make sense. I think it's hard for someone to, I know the question about AI came up, but it's hard to think of a, you know, unbiased AI model that can really make sense of that without, you know, people with expertise like on this call today could try to do. And finally, I'll just say that, you know, GI is very important. There's some people who are facing more GERD or reflux, stenoses of the GI tract, flow to the kidney and gut. We really need to prevent pre-diabetes and diabetes as well in the long term. So I think, I mean, there's a lot to do in the future, but I think it's a very important question.
So there's plenty there for a whole conference. You know, these are things we can be talking about, you know, for a while. They're really important. And I was interested to learn about your background as a PhD student, because Hangmei Mu, who was part of the call earlier, she is actually a mucosal immunologist. So I'll have to introduce you guys to sort of share some interest. You know, one of the simplest things about nutrition in kids with Myhre is that those with severe autism, they just eat a very restricted diet, right? 5 favorite foods. So you've got that whole challenge, that barrier to good nutrition. The other thing that we haven't talked about, but it's kind of in the mix there when we talk about GI, is the seemingly omniscient constipation. Currently, the only thing we can do is sort of quantify or describe it using the Bristol stool system, but that is such a challenge too. And it's hard to know if the first, poor diet, is related to the second, the constipation. Or there are other things that we should be thinking about. You mentioned microbiome, Joe. I think that's a really interesting idea. We've also wondered about blood flow. Any reason to think that there's ischemia? Is there any fibrosis that goes into the intestine? At Mass General, we've done some manometry studies and some motility studies, just like a small number of children, but not picked up anything distinctive. So there's a lot there in terms of the whole field of nutrition and gut too.
For sure. And that will lead us nicely into promoting our last speaker of the day, Professor Jack Gilbert, who's going to be talking to us about gut health and microbiome. So that's fantastic. This is a nice introduction. So just moving on to another pre-submitted question, and then we're going to definitely get to the chat. So everybody, don't feel like we're not answering your questions. We've got loads of time. So Dr. Valerie, a natural history study was published in France for Myhre syndrome. And can you tell us a little bit more about the ongoing research in France for Myhre?
Yes, with pleasure. So we have published a monocentric retrospective study, longitudinal study for Myhre syndrome. The aim of this retrospective study was mainly to describe in a unique center, all children were followed in our center, what was the events for each child, what they were coming to the hospital, at what time was the diagnosis performed, what was really if they have any surgeries. And it was quite important to be able to have an idea of the quality of life of these patients and what was their daily life. So we are now doing the same type of work, but in a prospective study. So collecting data and seeing the patients every year and trying to fill a registry and also collecting samples. So to be able to better describe the natural history. So we have a fair number of patients. And the most important for me is that we know the patients and we are following them regularly. And we know each physician following the patients is aware of Myhre syndrome, and it is always the same physician. I mean, the same cardiologist or the same ENT specialist, and this is quite important. So this is for the clinical part. Now we have also generated a mouse model, which is a knocking mouse model, and you have heard a lot of mouse models this morning. So we are doing exactly the same type of work, phenotyping our mouse model to first phenotyping, because we also have the chance to have a mouse model mimicking the human disorder, and this mouse model will be quite helpful to further understand the pathogenesis of Myhre syndrome, which is not well understood, and then it will be useful for preclinical trial, as you have already heard, which might include losartan or any other drugs that we can use. So we are doing research on this mouse model. Now, I will say that the most difficult for us, because France is a small country, is to have fundings, to have academic fundings, and to find people, good people following those research. So we are doing our best. We are trying to do our best.
Oh, amazing. Fantastic. That sounds absolutely incredible. And thank you for doing that. Angela, anything to add on onto that?
I just wanted to ask Valerie, do you see patients outside of France? Are they allowed to come and see you? Yeah.
Yes, of course they are allowed, because it's especially from Europe, it's quite easy. We are receiving in our center patients from outside the country. Yes.
Yeah.
Fabulous. Thank you. Thanks for that update. So we're going to get to some of the questions in the chat now. And as I said, everybody chime in as well and add your thoughts too. So a question here, and perhaps Angela, this one for you first. How often do Myhre patients have severe autism? And alongside that, I know there's been lots of discussion about being nonverbal that comes with that too.
Very good question. First of all, the spectrum of ability, what's typical, atypical, is just growing wider and wider. As I'm meeting so many of you right on this call, I'm learning about more abilities. So we tend to think though of I'll just talk about development in general. Developmental delays, just little issues, almost 100%, but not 100%, almost. And I just mean there might be challenges in school, there might be some delayed milestones. Actual intellectual disability, which we define as an IQ usually around 70 or 75, is certainly not present in the majority, not at all. Autism spectrum, if you broadly define it to include people with social disabilities, social awkwardness, social issues, it is quite high. And again, this is an international audience. I'm focusing more on the patients that we've seen. Severe autism, in our opinion, it's the minority. It is divided into different categories, very severe behavioral problems. And then the patients who are nonverbal, in our series, I think we have about 5 patients. It's really a devastating feature. The parents have said to me, they just want to hear their child say, I love you. And it's really quite devastating. It is the minority, but it is real.
Thank you. Thank you for that context. Dr. Scamenti, hearing loss, a specific question here, but I think this has relevancy for other people in terms of understanding. Any reports of noise from patients due to the morphology of the ear bone or structure, where the patients are themselves experiencing noises that they can hear due to that structure? Oh, I will just unmute you. Hang on 1 second.
So for many forms of hearing loss, patients experience tinnitus, which is ear ringing and noise. And so I don't think I'm looking at Dr. Lin. So Angela, did we, when we did the analysis, the data, do you have a number for the patients that reported tinnitus?
No, we didn't. And by the way, folks, I really do encourage you to listen to the slideshow because it's one of our best pieces of research. Lisa was a very active co-author. We all did this together, and we have pretty good numbers about everything. For example, she gave a beautiful introduction about the types of hearing loss, and then the next question might be, which patient should have imaging of the inner ear? And it's usually done by what's called a CT. Sometimes you pick it up when you're doing an MRI. MRI and CT are different. But if there is a concern that there is a conductive loss or sensory neural, you just want to define it. You would do a CT of the inner ear region.
Right. And that's really important because many people, especially kids with developmental delay or autism, will get an MRI, but generally, if you don't ask the radiologist in your order specifically to do the temporal bone, or at our institution, we call it internal auditory canal protocol, or IAC protocol. Mm-hmm. And so it's just not it's going to show up in the head, because when you need to look at the inner ear, you know, if you think about a brain MRI, we're basically making cuts of the head. So like if you're going back to the loaf of bread and looking at different levels within the head, if you're not making fine enough cuts in the inner ear, you'll miss some of the subtleties of those findings. So it's not just an MRI. And so it's really helpful to have an MRI to look at the inner ear structure.
The slideshow was truly a collaboration. Patty Schultz is, I think she's slide number 3, because I dedicated this to all of the community who helped me understand this better. April Lenord, who's the mother of Alec Bruneau, she was a big help too. And people literally helped educate me in particular to what was going on with their children. I generally don't say patient names, but in this milieu, I think it's okay.
Yeah, Patty's an amazing patient advocate and board member, and yeah, so thankful for her.
Just to
yeah.
add on to
This
that.
is really interesting. So your patient, I just saw something pop up in the chat. So there's a patient with enlarged vestibular aqueduct syndrome, and so we've seen this, but it's not typical. And given our recent experience with doing genome sequencing in patients with Myhre syndrome, there are genes that are associated with enlarged vestibular aqueduct. So it may be worth looking.
So let me just pause and expand on that. One might think that having a child or having yourself with a gene abnormality, that's plenty in life. But we have found that people increasingly who have one genetic disorder can have a second. We use the expression of dual diagnosis or co-occurring. In our series with Myhre syndrome, we have found this too. So what should you do? If the feature is really different from core Myhre syndrome, it's worth doing some additional testing. One could say, though, that Myhre syndrome is a spectrum, and maybe a new feature like EVAS is really part of it. We just haven't found it in enough patients. But it's worth talking to a sympathetic geneticist, such as those of us on the panel, because we will often send off additional testing. And I'll just leave it at that. Joe, I'm sorry, I didn't mean to cut you off.
Yeah, I just wanted to add, this question about MRI, CT is super important, and important for people to talk to their doctors and specialists about it, because, I feel like, we definitely run into EVAS in other situations, but in terms of CT of the auditory bones and the IAC protocols that we all have, I feel like they're getting used, less and less with the advent of more genetics. And so maybe some of that will be picked up by MR, but, CT can pick up some things that other things can't. At the same time, there's all the, risk benefit of CT, especially. So I feel like it's a key question to discuss the details of what kind of imaging with people, just to make sure they're getting the exact right kind for what they need. Because you can see different things with different ones, but because the genetics of hearing issues, keeps increasing, I felt like a lot of our ENT colleagues have been using the CT less.
Joe has mentioned several times the idea of guidelines recommendations. I'll just do a little sidebar comment. So the gene reviews that was created this time last year, was the first step. It's only a first step. They're not called evidence-based guidelines. They're more like it was an expert consensus of folks who put it together. Where our current MGH series based on 47 patients, we'll try to refine our personal guidelines based on our personal patients. Looking ahead, starting in July of next year, we're going to probably start at the time of the conference, we're going to start to work on evidence-based guidelines. These take a long time. I actually have a little talk on that. They take at least a year. I've been working with the Turner Syndrome group to do one. And in order to do evidence-based guidelines, you need to have the evidence. And the evidence are these papers. These papers just take forever for us to do. So the point is, we can certainly start next July, but it will take a while to get them out there. Thanks, Joe, for bringing that up.
Mm-hmm. Thank you. Right, hypertension, a question on this now. Are certain patients more susceptible to pulmonary hypertension, and what are the warning signs?
I'd be happy to take that on. First of all, we need to talk about the types of hypertension, high blood pressure. The common one that we think about is systemic. It refers to your body, your arms, anything outside of your heart. The second type is called pulmonary. Pulmonary hypertension is known. It's difficult to treat. What you try to do is look for an underlying cause. In Myhre syndrome, it definitely is reported. And I don't know if Valerie has any thoughts on this. We have often wondered if it is a primary pulmonary hypertension or if it is secondary to something that is unrecognized. Now, this is going to get a little fancy. Here we are talking about higher blood pressures in the lung field, but one of the causes can be the heart itself. And there can be reasons why there is high pressures in the heart that reflects upward. There's nothing about the cardiovascular system that is isolated. The lungs, heart, liver, they're all integrated, they're all together. And so when you have a concern about high pulmonary pressures, you have to think about the heart below it too. It's kind of more for this discussion, and I hope that just gives you a bit of an answer.
Thank you.
And let me add to that too. We have a number of patients who have obstructive sleep apnea, and obstructive sleep apnea can contribute to that. So having if patients are having difficulty sleeping or difficulty at night, we do recommend sleep studies and treatment.
Great point. You know, unlike systemic blood pressure, which you can evaluate by putting on a blood pressure cuff, you know, it's easy. Pulmonary hypertension is really difficult to evaluate. Doing an echo doesn't tell you what's going on with the blood vessels. You can do pulmonary function tests. You can do a sleep study, but oftentimes you need to do a catheterization, which is invasive, but it's really the only way to get at that type of data. Thank you.
Changing subjects slightly, gene editing has come up a couple of times today. I know it's a lot in the news and all that kind of thing. Dr. Shea, you and I, I'm fortunate enough that you are my son's geneticist, so you and I have had discussions on this before, and I loved our discussion about how we go about thinking about gene editing when we're thinking about such a systemic issue such as Myhre. A lot of examples can be given of gene editing when it's very, very specific. How does one think about gene editing when it comes to Myhre that can affect so many body systems?
Yeah, such an important question. I think a great question for the whole group. I mean, one paper that I will point out was, you know, a recent study from one of our collaborators in Australia. This is a collaborator who I worked with on a past rare condition that we found for the first time. And this investigator, she, you know, looked at SMAD cells where they put in the one change and it was not there in the other. And then they looked at how the SMADs were interacting in that way. And they looked at the transcriptional changes, meaning the RNA changes. And the goal is to know, you know, are we trying to affect the one copy that's changed or affect the more typical copy? And I'm interested how the group here, especially the panelists, feel about this, because, you know, to design the best kind of treatment strategy, whether it's CRISPR, whether it's gene editing or modulation, and you need to know, you know, this whole issue about gain of function or dominant or, you know, is it dominant negative? I think that was the one thing that came up from the most recent paper. And I know Valerie's group was one of the first that sort of got at the pathway question first. And then I think, you know, all of us in the US are, of course, now developed this huge consortium to try to figure this out. I'm interested in how the rest of the group feels about like the two different alleles and which one and what dosage should we be heading for going forward.
Joe, can I just check? You're talking about the Dunwoody lab paper?
That's right. So the Dunwoody paper
Proposing dominant negative.
Put the, you know, variant in, you know, a human cell. It's limited because it's a human cell line. It's not a model organism cell line. There's some limitations about the dosage and things like that. But, you know, it's a, you know, interesting model to look at. And I want to know how people feel about comparison with everyone doing fibroblast studies, because we need to do more of those fibroblast studies, right? There's some that are banked now, but there need to be more done.
When that paper came out and I showed it to our group, we just didn't know what to say. We weren't sure if the effect that they show really just represented their research model they created, or whether it really could reflect on, quote, Myhre syndrome. I don't know if Lisa saw it. I think Bert is still on the call. I don't know if Valerie's still here. Oh, I'd love to know what Valerie thought.
Yeah, I think Valerie's having some connection problems.
Oh, it's too bad. Bert, are you still on the line? Oh, we're losing them. See, what happened is in 2012, Valerie's group, and then the group from Italy, Tartaglia, they identified the gene. That was huge. That was great. So we now have a gene. The next thing you have to do is you have to decide what exactly is that gene doing? What's its function? Those are called the functional studies. And they did present some data, but as I recall, it was limited. This is no criticism, it was just limited at the time. And the mechanism that was proposed with this idea of gain of function activation, and it fit really nicely with what we were seeing clinically. But I think since then, more functional studies were needed. Joe or Lisa, do you have any comment to my little synopsis there?
You know,
go ahead,
more needs to be done along the cellular line. And, you know, Bert's on the call. Bert, we're just talking about more cellular studies. We liked what you're talking about in terms of models of fibrosis. And, you know, the fish seems like a very good model that could be tested pretty thoroughly, right?
Angela, did you have a question for Bert in particular?
No, Bert, I'm sorry. You were there, then you were gone. Now you're back again. What happened was we made this has really been a great panel because we're having fun talking. And we were talking about the Dunwoody paper, the one from Australia, and they created a system, it was a little bit different. And they proposed that there was sort of a dominant negative mechanism rather than just, you know, gain of function. And I was just polling my colleagues to see if anybody had any thoughts on it. I absolutely have no opinion on it. I don't know how to critique it.
Well, actually, we have some preliminary data that the SMAD4 protein is getting some additional compounds added to it, something we call sumorylation. And it seems that the mutant protein gets more stimulated and gets less broken down eventually. And it changes also a little bit how cells proliferate. So cells tend to proliferate a little bit less in Myhre syndrome than in other entities. But in about
wait, pause there. Did you say in your model they proliferate less?
Well, at least what we see on the fibroblast, but we're still looking further into that.
Oh, to me, that's counterintuitive. I thought that what was going on was we had proliferation, you know, I don't know if that meant actually excessive cell, you know, division, multiplication, but well, that's interesting. That's why we had the bench work.
Amazing, amazing. Gosh, we're hearing it hot off the press. Right, changing gear slightly. This was brought up a little bit earlier, Angela, but for the sake of everybody on this panel as well to contribute to, it's an area that gets discussed in our community group frequently. Females with Myhre and their ability to have a family, and if that's even possible. Could you touch a bit more on that subject matter?
Oh, I'm going to let Bert do that. But Bert has been systematically collecting families in his clinic around the world, the literature. We identified the one in Brazil, thanks to one of our members, thanks to Ana Musa. And then I identified a family in, I'll just say in the West Coast. You know, it's funny, so often I try to be so protective of privacy because that's what a doctor does. And yet I'll often have families say, Angela, we know about it already. So, but I'll let Bert talk to you about fertility.
Yeah, so I think there has been a huge change over the past years in thinking about fertility Myhre syndrome. I think until maybe 8 or 9 years ago, there were no reports at all of families with Myhre syndrome. And we actually, I think we were one of the first to identify a family of a lady with Myhre syndrome who had 2 children also affected with Myhre syndrome, but she had major fertility problems. So she had many cycles of in vitro fertilization. She had many miscarriages. Of course, this is just one person, so it's difficult to generalize these data. Most families we see with Myhre syndrome, actually the father is affected with Myhre syndrome. So at this moment, I don't have any reason to believe that fertility would be reduced in men with Myhre syndrome. We are not sure about women with Myhre syndrome. There might be reduced fertility. We don't know. I think it's important that if there is a child wish in a person with Myhre syndrome, that's important to talk early about that. Also to talk early about it with a gynecologist. There are tests that you can do to look at how much egg cell reserve that there are still there in the ovaries. So these are hormonal things that you can check. And of course, it's also important to talk about recurrence risks within this option. Because we do know that persons with Myhre syndrome, if they have a child, that the child has 1 in 2 chance of being affected as well. And we know that there is quite some variability in Myhre syndrome. So it's not certain that if yourself are relatively mildly affected, that you might have that the child that would be affected would have severe, for instance, developmental problems. So that's also something to take into account and to talk early about that with the gynecologist. There are many options, from checking very early in the pregnancy and even pre-implantation genetic testing. So there is an in vitro fertilization procedure where we check the embryos before we put them back into the womb of the mother. So that's there are many options. I think if there is a child wish, talk about it very early within the family, but also with the gynecologist. And then we can figure out what the options are.
It's a big topic, and I think that I'll try to summarize as best I can. We'll talk about female now, right? Number one, for anybody contemplating parenting, you have to take into account your own psychosocial, quality of life, milieu, your ability to become a parent. Number two, I think there's the issue of the variant. It does seem to be currently the arginine 496 assisting that is most likely. I would also say number three, we need to think about the uterus. If this is a woman who had early menses, who had really very severe periods, was actually on hormonal suppression, you'd have to wonder, is that uterus suitable to bear a pregnancy to? Is there anything that could be stimulatory? Could we actually lead to a process that long-term might lead to hyperplasia, metaplasia, et cetera? I don't know. I'm just saying these are very weighty discussions that would be needed.
Great, thank you for that context. And then just need to shout out to Dr. Burt for becoming an unofficial panel member. So thank you for that. We've dragged you away from your Saturday night even longer.
That's okay.
Great to have you here. Okay, a question about mental health. Has there been any specific mental health issues that have been identified in Myhre patients, i.e. depression, anxiety, psychosis, and are any treatments, have any treatments been found that have had positive results?
I can start and everybody can join me. So of course, we've already talked about what about cognitive abilities, cognitive challenges. Then we've talked about social challenges, including autism. Our philosophy about autism is there is no drug for it, but you treat the comorbidities around it. ADHD, some anxiety, some depression, rare cases, but known of schizophrenia. But this does not mean that it is a common part, but it has occurred. And these features are less about Myhre syndrome. It's about the fact that when there is a gene impacting brain function, it doesn't necessarily have very selective areas of the brain or selective functions. These things are sort of co-occurring in general populations too. Lisa, Joe, anybody else? And so we definitely do try to treat them, but very carefully. You have to be careful about treating ADHD with a stimulant.
I think early neurodevelopmental assessments and, neurology, neuroimaging is going to tell us maybe a little bit more, right? If there is something to pick up there in vasculature, that'll be important. But if it's more subtle, that beyond our MRIs can measure, we're going to need to do a lot more hard work at what medicines are helping with neuropsychiatric symptoms, especially in older individuals. And that's why glad that, so I see kids and adults, but I mean, we need the whole community really, thinking forward in terms of the future psychosocial development.
We thought we had a marker. Many people in the early years of taking care of these people will tell me about these little white spots in their brain. They're called white matter hyperintensities. And we now have a sufficient number that we do think it is part of Myhre syndrome. We think it represents a micro cerebral vasculopathy. These are very tiny blood vessel changes. We think it's developmental. It's not something that's acquired over time, but we don't have a natural history. We haven't had patients who've had them at birth, 10 and 20 years old. But we do think it is a marker of Myhre syndrome. But it's seen in a lot of other conditions too. And we have not yet correlated the location of these little spots to the performance or to other different features. So we're definitely following it. But that is what an MRI can show you. Major brain malformations in Myhre syndrome are very uncommon. You can have a problem in the back of the brain. It's called the Chiari, the posterior fossa, but we don't see major brain malformations. It tells us something about how the gene must act in utero.
And am I right in thinking that you said the possibility in the future a brain and spine MRI might become something that is recommended?
We are not at the point where I don't think we're going to end our paper by saying everybody should have a brain MRI. We certainly say that you should have a low threshold. If there's any concern about a seizure, for example, any asymmetry of the gait, any asymmetric neurologic features. The concern about the spine is very real. It comes at two ends, the top and the bottom. At the bottom of the spine, there can be a situation called a tethered cord. And it's not as a classic severe tethered cord, it's something milder. And then up in the cervical region, there can be problems related to progression over time. So you've got the spinal cord itself, as well as the vertebrae that surround it that can be abnormal.
Great, thank you. And I think one more question. How do people come and see you at the Myhre Clinic, Dr. Lin? What does that involve? And just a little bit of insight, I think people would appreciate on the tremendous work that goes into seeing somebody with Myhre, and for all of you, I
wish we could see every person in the world. I wish we had continuous clinics. Number one, I'm really limited to just one Friday each month. Our clinic space is limited. Number two, most people don't realize I only work part-time. My employment is really like 0.125. So my patient time is only on Friday mornings. And the rest of the stuff I do is really almost volunteering. To prepare for this, it takes 6 months. And the reason is that our schedule is already crowded. We're actually filled up to probably April and May. So we need some time to prepare. We need to learn all the doctors. Doctors, travel. They've got their own other things. So we just have to prepare everybody. And then the other part is the insurance clearance. And sometimes it's easy, sometimes it's really hard. I unfortunately don't have a coordinator who would do this. I don't have an administrator. It really is me as the doctor, the researcher, and the coordinator. So there has to be a lot of, the families have to be willing to really help out. I wish I had somebody who could be the front desk to take care of it, but it has to be a relationship. You have to be willing to use virtual communication. I will, occasionally use an email just to communicate, but we have to do it through a portal. It has to be secure, and that's how we send reports. So it's asking a lot of a family, and it is difficult for everybody. But of course, I think once you get here, it's worthwhile. And we see we have a core of 5 appointments: genetics, cardiology, pulmonology, PT, and ENT. Everybody has to see everybody. We're really not able to fairly process outside evaluations. We need to see the people. We need to have the reports. We have to do it sort of our way. And then we can add on. If somebody has concerns about skin, GI, endocrine, puberty, et cetera, we add on those visits too.
Great. And for Dr. Schimenti, from your side, I know geographically speaking, we obviously have people internationally, and then as we know, the US is a huge place. So we've got Angela on the East Coast, Joe on the West, and perhaps, you know, you're slightly in the middle. So
we are in the middle. So we have a number, yeah, we do have a number of options. And so Mayo is well known for our ability to provide coordinated care. And we do have a team of individuals who have expressed a desire to be the world expert in care of Myhre syndrome. So we do have a good team. Mayo does have a business office and will help with insurance. And then we do take time, review everybody's chart, make sure that we make a list of everything that hasn't been done and needs to be done, and then develop a long-term management strategy. So it's not a one and done. We actually follow people. For international patients, Mayo has an international office, and physicians can refer to the international office. And then what happens is then that depending on the age of the patient, it gets sent to a provider who's the screener for the international office. And then it comes to usually, you know, if it's a condition that I take care of, then it will come to me for, you know, basically how do we organize this and make it work. So.
Great. Thank you. And Dr. Shea, from your side, obviously, I know, you know, on the West Coast, we have a collection of families. We've been lucky enough for the patient community to put their locations on a Myhre map. So we know that there's people in the area. And similarly, from your point of view, I know you see a number of us.
Yeah. I mean, you know, great resources here in the San Francisco area for people who are around. We also have, you know, an office that can help coordinate for outside visitors, an international office, but I want to, you know, make sure that people can go to where is most convenient for them. And I'm glad there's an increasing network of providers who can say, like, you know, we have some expertise in this and we want to make sure that people get the best multidisciplinary care possible. So glad to see that the global, you know, awareness and sites are increasing where people are going to be really getting good care.
Amazing. That's fantastic. Well, we've covered so many topics, and just want to say a huge thank you for being part of this Q&A panel. It's the first time we've done something like this. Hope you'll agree. It's been really worthwhile, and we'll do it again. And obviously, we're meeting again in person in July in Philadelphia for the conference, so we can expect more of the same. Yeah, thank you all very much for your contributions. We really, really appreciate it.